Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. Today is the 136th episode of the Codecast, and it is the last Tuesday of the month, May 26, 2020. So it's Top 10 Tuesday. First, I hope everyone had a nice Memorial Day weekend and was actually able to see some family, hopefully, and some friends that you haven't seen in the last 10 weeks, since most of the country now is on a soft opening. And now we can jump right into the work at hand. So I've had some crazy coding questions that had me going outside the box to answer. Some are COVID related, some are not, but it did bring me just some, enlightenment on what's going on with everybody, and realizing that there are some interesting scenarios that shows that everyone is nervous about how the telecommunication delivery of medical care is going. And so we're going to have some hopefully some good questions and answers to address some of the issues there. Our Top 10 Tuesday is also brought to you by CAHIMA, California Area Health Information Management Association, ILHIMA.org. Okay, so number one says, Terry, one of the nurse practitioners in our group is asking me if there is a code, no charge, that we can use to keep track of telehealth calls attempted, but the patient doesn't answer or call back. Example would be a patient they tried to call at her scheduled appointment and the patient doesn't answer return calls and then ends up having a heart attack or something. So should we be keeping track of that? So my response to that was actually probably not what you think. What I said is, well, first of all, how do you handle that when the patient actually would come into your office? So do you keep track of all no-shows? Do you make sure that you follow up and contact that patient? What are you doing for that liability? Because your liability would be the same, whether they're coming into the office or they're just being contacted through telehealth. So that's what one of the things that Medicare has said, and that's why they changed the place of service for a lot of the services, is it's the same as if the patient would have come in. They're trying to have you keep some continuity of care, meaning that keep things consistent. If you would have tracked that when the patient came into the office, then you should track it if they, miss it when they're a telehealth call. And I would just use, your common sense on that one. So if you do track it one way, track it the other way. Number two says, when would we use the CS modifier? So I think I addressed this in a couple of podcasts, but I wanted to go ahead and bring it to your attention. This was a modifier that actually was brought up on the 430 FAQ sheet for CMS. And it said the CS modifier is only used for COVID-related claims for testing and treatment, because if you have a covered diagnosis, Medicare will waive the share of cost for a patient during the public health emergency, but only for COVID-related claims, testing, and treatment. They may allow for an office visit if they were exposed and need a consult and a test to decide if testing and treatment is going to continue. But there's a list of diagnoses that Medicare has, and I invite you to check that out. So that is just to waive the out-of-pocket, again, COVID-related. If you put it on any claim that's not COVID-related, it'll get denied. It won't even get paid, so you would be holding up your cash flow if you do that. Number three, it says, I noticed there are global days on telephone calls 99441 to 99443, and also the calls for QHPs. So how often then can these be billed? So let's say an example, a patient called us yesterday and we had an audio phone call only of 20 minutes. So we coded 99442, but then today the patient calls back to speak with our nurse practitioner and wants to ask more follow-up questions, again for the same problem, and won't use the audio and video platform that we have. This call was another 15 minutes. So can I code the 99442 again for today's call? So you're not going to like the answer on this, but the answer is no. The CPT book says if the telephone call refers to an E&M service, and remember, phone calls are E&M services, performed and reported within the last 7 days, either requested or unsolicited patient follow-up, or in a post-op period of a global procedure, then the service is considered part of the previous E&M service or phone call and is not separately reported. Also, do not code for phone calls and portal digital services within the same 7 days as well for the same problem. Remember, phone calls, digital services, anything like that, those are considered to be cumulative over a 7-day period. So unfortunately, that is the problem. If you have patients that keep calling and thinking this is really easy now, I can just call the office whenever I want and get an office visit and over the phone, and that's not the case. There has to be a week, a 7-day period in between, otherwise you're not going to get paid. So keep that in mind when you're being overly flexible on the phone call codes. You really want to press your patients to really try and get either that smartphone capability for FaceTime or for Skype, or to engage in your EMR audio video conference call that you have available. Number 4 says, since 2020, CPT informed us of a change in reporting bilateral procedures for add-on codes. Yes, I remember with that. And it says, I know we've been dealing with some major billing headaches, for example, facet and transfemoral injections. So this is pain management question. It says the base code is still reported with the 50 modifier. So for example, 6448350. However, the codes for each additional level are to be reported as 2 separate line items, appending the modifier RT and LT. So 64484 and 64484 with LT and RT. We've been told so far by Medicare Max, Novitas, and Palmetto and First Coast that they're rejecting the RT and LT line items. However, Noridian has been more agreeable. So as they continue to require all bilateral procedures, including add-ons, to be billed with the 50 modifier, disregarding the CPT instruction, should we continue to do that? Several commercial payers are also denying this billing method based on utilization levels. Okay, so I think the policy didn't catch up to what is in CPT, didn't catch up to what the payers are doing. So my advice is to check bilateral billing policies for all payers. If no other reference to a directive is found, it's probably best to continue to report the 50 modifier with add-on codes, and if at some point you need to appeal, use an EOB from a payer who did pay as a precedence for using the 50 modifier and add-on codes. And for those of you that don't do pain management or any kind of surgical coding, this was something that came up in a CCI, an NCCI policy change and an NCD, National Coverage Determination, saying that on add-on codes, the 50 modifier would be exempt. It came up on the CPT as well. It's actually an entry, but I'm not seeing that policy has been catching up to some of the payers. And then you've got MAC payers saying, well, we're still using it. So I would really look and see what each individual payer tells you to do. I know that's not probably the best answer, but it's the only one we have for now until the policies and the CPT instruction catches up to one another. Number 5 says, Terry, our doctors would like to start billing TCM services. This is a client I have in California, because a consultant at our local hospital told them they would make a ton of money. But in reading the rules, I'm not seeing that. So can you give us some clarification on this billing time period? We understand the provider needs to initiate the call on the second day of discharge and bring the patient back into the office within 7 or 14 days. But what day do I bill TCM? Let's say I get a discharge today and I get a call on Wednesday and the patient sees the doctor on day 7. Is it all bundled, or how does this work? Okay, so I've done a podcast on transitional care management, which is what TCM is. And it means your physician, and this is actually a cardiology practice of mine, has decided to take on the entire patient's profile, transition back to their kind of life. They call it the Domus area or their community, meaning let's say they're, like I said, they're cardiology, and that patient was in the hospital, let's say for a slip and fall for a hip fracture. Well, it's going to be up to that cardiology practice and the physician specifically, because the physician is responsible for a lot of the visits in this and a lot of the encounter information, that they have to call them within 48 hours or 2 days of discharge, and it's 2 business days. So if they're discharged on a Friday, you have till Tuesday, but discharge Monday, you have till Wednesday. And so they have to call them. There has to be two-way interaction between the patient and the physician. That can be audio only because it's just basically an administrative thing they have to do. And then within a 17 or 14 day, depending on the medical decision-making, moderate or high, they have to bring the patient back into the practice for a face-to-face visit. Okay, and that is not billed. So that is not an E&M service you can bill for. That's going to be inclusive of the transitional care management services. And then when the patient, also during that first 14 day or first 7-day period, you have to make sure that you're doing all the coordination of care. So scheduling their physical therapy, their occupational therapy if they need it, making sure they've gotten all their prescription medicines, even if it doesn't apply to your office. And then the patient, basically, you have to deal with them for 7 days, so 29 days after discharge, and make sure everything is good and be available should they have a question. And that's all bundled into the transitional care management codes. So to me, and I've talked to a lot of practices about this, I don't know if you've actually looked at the reimbursement of the 99495 and 99496, but it's not that much more than a regular established patient office visit, maybe $20, $30 more. And you're doing all this work. So if you want to do it, knock yourself out. That's totally fine. But as far as it being a moneymaker, it is not. So it is all bundled into one of those codes. Now, Medicare did put out something in 2017 saying you could bill that service on the day of the face-to-face encounter, but I wouldn't do that. That to me is like giving somebody a Christmas present early. You know, they're not grateful for the next 14 days, and you have to make sure that you're doing all of the services for 30 days. So to me, you bill it on the very last day. And that's how I responded to that Coding Corner client. Number 6. Okay, so this is a DME question on CPAPs, so for sleep medicine. So I put this one in here because actually the end of it was kind of funny. It says, Terry, my question is in regard to DME. If we set a patient up on a CPAP, Medicare requires that the patient have a face-to-face visit after 30 days and before 91 days post-op or post-setup to document compliance. Do all of the electronic visits count as face-to-face visits? I have a friend that says you can just use audio only, and I did not understand that to be the case. We are only doing and charging for audio-visual visits using the evaluation and management visit codes. Can you please clarify? And by the way, you'll laugh at this. I called our Medicare rep, and she said that you may want to check with Terry Fletcher. She's a consultant versed in sleep studies. Okay, then. So I know I audit for Medicare, but I just thought that was funny. I was like, okay, well, yeah, check with somebody else because we don't know, but that was funny to me. So you have to have a face-to-face. You can have an audio and video telehealth visit, and that would cover your face-to-face visit, but you cannot just do audio only. So your friend that said that's okay, I have not seen that on any directive, and you want to keep, again, the continuity of care. And unless you see it somewhere in writing, don't do it. So what the actual Medicare rules are is that you do have to have that face-to-face after 30 days and before 91 days post-setup. Number 7. Hi, Terry. I have a question on adding information to a medical record after it has been closed out. Can we do it? How much leeway do we have to give to the physicians to add the information later? And does the physician have to add it, or can an ancillary staff add it? This actually came from one of my clients in San Diego area. So I'm actually going to do a podcast on this coming up because I think it's more than just a regular answer to a question. But I'm going to give you 2 answers to this one. First of all, there's something called a late entry. And this comes from the Medicare Integrity Manual section, or I should say Chapter 3. A late entry is made to the medical record when information that was absent from the original entry is recorded after the original note was created, dated, and signed, and possibly billed already. So a late entry basically gives that additional information that wasn't in the original entry, so it was omitted from that original entry. It also bears the current date, so it's added as soon as possible. It's written only if the person documenting has total recall of the omitted information and signs the late entry. So an example would be, a late entry following treatment of multiple trauma. They might say, quote, the left foot was noted to be abraded laterally, and then John Doe, MD, 3/15/2020. So that could be a late entry. But you want to make sure that it's the person that actually has that total recall of that information. The reason I say that is a lot of people call every late entry an addendum, and that's not correct. So the first one says it just wasn't included, was absent from the original. The addendum means that it was not available at the time of the original entry. And so addendums are typical for contracts we usually see to update terms and conditions. However, an addendum to a patient's medical record has specific rules that must be followed to avoid potential inference of a fraudulent note. So addendums made after the claim is submitted are not considered when Medicare reviews the record already. The addendum should also be timely and bear the current date and reason for the addition or clarification of information being added to the medical record, and be signed by the person making the addendum. So for an example, an addendum note could say the chest x-ray report not available for review on March 1st was reviewed and showed an enlarged cardiac silhouette. Jane Doe, MD, 3/15/20. So I would strongly recommend that that's your physician. But I'm going to expand on that because there's also rules on corrections and what it also says in the integrity manual in one of my next coming up podcasts. Okay, so here is number 8. How do I bill for a selective right and left renal angiogram? My physician said it should be 2 to 3 codes, but I'm lost. Okay, so what it used to be, meaning that before 2015, I think, it used to be several different codes. You'd have a catheter placement and then an injection code or a radiology code that reflected the injection code. And it basically was an imaging code. So the injection, the image was the same radiology code with a modifier to reflect it was done in a facility. You leave the modifier 26 off if it was done in your office. But as of 5 years ago, or I think maybe a little bit longer, we have combined codes now for the renal selective angiography. It also includes a bilateral. If it's there, we have one for unilateral, one for bilateral. And if you have separate poles or separate blood supplies to those kidneys, so separate arteries, it's still going to be part of that code. They call them accessory renals. So for a right and left renal angiogram, you would code 36252, no modifier, because the code itself is bilateral. That includes your catheter placement and your imaging. Number 9, now we're getting into some wound care. 2020 debridement question. So how do I code for subcutaneous tissue debridement? Includes epidermis and dermis, 28 square centimeters over the low back region. How do I code for that? You would code 11042 and then an add-on code 11045. So you always want to know how far down the debridement goes and what is included in that debridement to be able to code for it, and the location. Otherwise, you may code incorrectly and not capture everything. And my last one, number 10, is a laceration without foreign body of the right forearm. What is the ICD-10 code for that? So I need to know if it's initial encounter, if it's subsequent treatment, or if it's sequela, meaning late effects, because your code is going to be S as in Sam 51.801. And if it was initial encounter, you would have a 7th digit A. Subsequent treatment is D, and sequela is S. So make sure that you have that understood as far as that 7th digit. That's going to make a big difference with the payer. Okay, so we're going to end today with a personal tidbit. I don't know about you guys, but I am starving for live sports. So what have I been doing? I actually watched a live UFC fight. I actually paid for it. How silly is that? But it was actually not bad. I'm kind of getting with a couple of my friends, kind of forcing me to watch it. And they're like, no, you'd like the sport of it, just the competition. And the one I paid for was great. The free one, boy, you get what you pay for. Wasn't that great? And it's not exactly my thing, but I thought it was interesting. What was weird about it is there was no fans. You could hear everything. And when somebody's kind of getting pummeled in the face and being kicked and hit, I don't know if that's such a good thing. You could hear every little thing that was being said. So that was different. Tiger and Phil Mickelson have a charity golf tournament that was actually played this past weekend with Peyton Manning and Tom Brady as partners. So I'm actually looking forward to that. And because I'm recording this podcast before Sunday, before that happens, I have no idea how that turned out, but I'll let you know next week. But I am excited for that because I need some sports. I'm absolutely going through withdrawals. But the best news this week for me was my Pittsburgh Steelers quarterback, Big Ben Roethlisberger, finally shaved off his beard and cut his hair. He was injured week 2 in the 2019 season. He had a season-ending injury and surgery, and he said he would not shave his beard or cut off his hair until he could throw it to a teammate without pain. And he started looking like Grizzly Adams. But this week he did, and now he looks like a real human again. And I am just so excited for NFL season to hopefully start. And I know my podcast producer and Joe Kuzma, and also a very good friend of mine, and I also write for his site and do podcasts for Steel City Underground. I know he's ready for me to help and get busy again with some of the season information. So I'm excited about that. But what it'll look like for fans is anyone's guess. We have had no basketball season. They're talking about coming back and just doing maybe playoffs with no fans in the stands. We've had no baseball season, and that would just be so weird with no fans out there. It changes the dynamic of the team. So I'm hopeful that we'll have an NFL season, but what that looks like is anyone's guess. But hopefully, like you, I'm just excited to see any movement towards opening up the country and the states. And let's hope that whether it's a slow opening, it's a quick opening, we get back to some kind of normalcy that doesn't look like what it does now, I'll be happy for. So everyone, on this Terry Tuesday, thank you for spending some time with me. As a reminder, please leave me a rating and review on iTunes or whatever platform you listen to. I truly appreciate it. And make it a great day and a great week. And I'll talk to you next week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.